Good morning. Welcome to the final grand rounds of 2024. We are excited for today's presentation, but before we get to that, a few announcements. The most important announcement, I will even say it twice, is that after grand rounds, please go up to the division, vote on the doors. There are paper ballots. I understand that there are currently ties, so we need more people to vote so that there are no ties. Well, ties are okay, but we'd really like your preference of who can win in multiple categories. So, and thank you so much to Elizabeth and Sarah for leading us in the doors. Our next grand rounds is actually January 16th. So there is no division meeting on January 2nd. There is no grand rounds on January 2nd. We will see you on January 16th. There's actually also no journal club in January on the second Tuesday. The next one will be February 13th. Casey Johnson and myself will be at Journal Club. Dr. Jonathan Kirchie will be at Grand Rounds on the 16th. Sorry for forgetting that. We'll also have evaluations after today's presentation. And again, the doors, vote on the doors after grand rounds. So without further ado, so glad that Dr. Danielle Fixen is our grand round speaker today. She has been able to really help us expand our knowledge of the use of cannabis or marijuana in older adults, has been speaking with many audiences, including long-term care audiences, community-based audiences, doing research related to this. So we are really excited to hear an update. Thank you.
All right. Good morning, everyone. You can hear me okay? Okay, perfect. Great. Yes, so I am very excited to be here today and talk to you about cannabis use in the older adult population. Just for those of you who may not know me, I'm one of the clinical pharmacists in the seniors clinic. So I am a faculty member at the School of Pharmacy, but I spend most of my time in clinic. So a lot of my knowledge and the cannabis items that I do is more related to patient, provider, and pharmacy education. I moved out to Colorado in 2013 for a pharmacy residency, which happened to be the same year that cannabis was legalized. So during my residency, I did a research project related to cannabis use for patients who had migraine headaches. And since then have just tried to stay up to date with all of the literature related to cannabis. And with moving into the geriatric realm, I have assisted patients with, trying to find cannabis options for those who are interested, but really ensuring that they are able to utilize these products safely and effectively. And so that's a lot of what we will be discussing today. Unfortunately, I have no conflicts of interest to disclose. Maybe that will change, but we will see. So learning objectives, we're going to start by discussing the cannabis regulatory landscape. We will explore what I consider best practices for cannabis use in our older adult population. And then lastly, we'll go through some of the most recent evidence we have for cannabis use in older adults. And I tried to really focus on the disease states that I see patients in our clinics who are interested in utilizing cannabis. Okay, so cannabis in the United States, just a little bit of background. It's legal in some states, but still remains a Scheduled I controlled substance in the United States. Most recently, recreational use is approved for 24 states and then medical use in 38 states. And I've seen these numbers grow since I started researching cannabis in 2014. And I honestly think that, in the next 10 to 15 years, we'll be at a place to where all 50 states will have at least acceptance of medical use of cannabis, just based on more and more research being completed. So just other things that I want to mention and that I try to discuss with patients is that medical cannabis is not FDA approved. So these products do not undergo, the extensive studying and research that a lot of our prescription therapies undergo. And so you really have to ensure that the product that the patient, is interested in trying or that they may go out and try to find themselves is a product that is safe. And we'll talk about, some of the safety concerns that we have. Lastly, so one of the bigger changes was in 2018, we had the Agriculture Improvement Act that occurred, and also known as the Farm Bill. Maybe some of you were familiar with that or heard about that. I know for me, the biggest thing that I noticed is advertisement of pharmacies saying that they're going to have all of these hemp products and kind of CBD based products and having medical claims for some of these products. So, what the Agriculture Improvement Act did was it removed hemp from the Controlled Substance Act. And so that allowed basically an abundance of hemp farms to be able to create more hemp related products. And as a result, we saw a lot of those products in places like Sprouts and CVS and the grocery store. In order to be qualified as a hemp product or to qualify under this Agriculture Improvement Act, it had to be a cannabis plant that had less than 0.3% of THC. So technically, it couldn't have a lot of THC in that product in order to be marketed and to be available in the US. So, what are FDA approved products that we have? Because I think this is really important. And a lot of the studies that we will talk about later today you use these products. So, we have Nabilone and Dronabinol. Those are two of our FDA approved products that we have. And then our only CBD approved product that is available, I think it was approved in 2019, is Epidiolex. So that is a CBD product. However, it is only approved for a very rare form of epilepsy, most commonly utilized in our pediatric population. So other than that, other than these products, we do not have any FDA approved cannabis products here in the United States. So, what are some of the concerns? And I wanted to share first, there was a study completed or published in JAGS that talked about cannabis related emergency department visits in our older adult population. And they looked at older adults they looked at basically cannabis related emergency department visits from a time period of 2005 to 2019. And they found an increase specifically in older adults having cannabis related emergency department visits. And one of the reasons that they wanted to look at this is because there was a lot of evidence out there in literature that there was an increase in older adults utilizing cannabis related products. A lot of these emergency department visits were related to cannabis overdoses and cannabis poisoning. And so I think this is just something, if you look at this time frame, this does encompass when the Agriculture Improvement Act took place as well. And so, just something to really be cognizant of. Along with some of these emergency department visits, also during this time, there were multiple studies coming out showing that the cannabis related products that patients were purchasing, specifically ones from external sources outside of the United States, contained a lot of contaminants in it. So a lot of these products that, said that they had CBD in them or maybe said that they were a hemp-based product actually had no hemp at all in them or no CBD at all in them. So they contain things like heavy metals and pesticides, and that was causing a lot of problems for patients. Another big issue that they found in studies is that patients weren't telling their providers that they were utilizing cannabis. Oftentimes, it wasn't that the patient was really afraid, but the provider just never asked. So I think that's something really important that we could do, especially living in a state that has legalized marijuana. I strongly suggest just asking patients if they use any cannabis or cannabis related products, so that we can help them discover which products may be more safe. In terms of safety, one thing that I usually suggest or that I always suggest for patients is finding a product that has a certificate of analysis, which is what this picture is on the right. So, since there's a lot of cannabis products available outside of dispensaries, so you can go to Sprouts and you just see a whole shelf of CBD oils and tinctures, or hemp oils and tinctures. A lot of those products have a QR code on them. And so you can take your phone, you can scan it over the QR code, and then it will have this certificate of analysis that's available for the patient. And it shows you the date that this product was analyzed, and then it shows you everything that's contained in this. I highly discourage patients to use a product that doesn't contain a certificate of analysis. And if patients go to dispensaries, I ask them to ask that dispensary, hey, can I see your certificate of analysis, so that they know where this product came from and that it was tested, so that they're actually getting what they should be getting in that product. Another thing that I just wanted to point out is, so as we have more legalization of either medical cannabis or cannabis, there's also a few states that have asked pharmacists to be involved in the dispensing of these cannabis-related products, which I think is really great. It is states who have medical cannabis. A lot of the states have, different regulations, but do have pharmacists there, which I think is a really great step to ensure that one, the patient is able to be counseled on this product. So if you think about getting a product at a dispensary where it's a bud tender. Sure, I'm sure they know a lot about marijuana and cannabis, but do they know some of the medication interactions, or do they know the disease states that patients should not utilize these products if they have? So having a pharmacist involved with that, I think is a great step in the right direction. I don't know that that will happen throughout the United States, probably not, but I think it is great that some states have adopted this. So, speaking of pharmacist involvement, some of the best practices for older adults I want to jump into. So, this is my checklist that I utilize whenever I'm talking about cannabis, or if a patient is interested in using cannabis for a medical condition. So, number one, what have they tried for this condition? Whether they want to use cannabis for sleep or for pain, what options have they tried, and then what happened whenever they took those therapies. Today, I will not be going through what first, second, and third line options are for things like sleep and pain. And so we'll jump more into other things that I evaluate, such as medication or disease state interactions, then looking at adverse effects that can occur, as well as monitoring that should be recommended, along with risk versus benefits, which is where we will really jump into the evidence. And before we talk about medication and disease state interactions, I want to just give a brief overview of why cannabis is utilized for certain disease states and medical conditions. So within our body, we have something called the endocannabinoid system. Our body naturally produces endogenous cannabinoids, which are shown here, so AEA and 2-AG. And these endogenous cannabinoids act on cannabinoid receptors. So we have CB1 receptors and CB2 receptors in our body. I created this very basic picture, but it's just to show the location of CB1 and CB2 receptors. So if you look at the receptors, you can see that CB1 receptors are primarily located in the central nervous system. And that's really important whenever we think about where our cannabinoids act. And we'll discuss that in a few slides. So CB1 primarily central nervous system, peripheral nervous system, whereas CB2 receptors are located in the GI tract, immune cells, and peripheral tissues as well. The role of our endogenous cannabinoids is to modulate a lot of the neurotransmitters that are listed there. And so, in a normal functioning endocannabinoid system where you have endogenous cannabinoids, they're modulating neurotransmitters. The function is to maintain our body's homeostasis. And so, you can just see a few areas that the endocannabinoid system helps regulate. So, pain, immune response, digestion, metabolism, as well as mood. So, then why would we use phytocannabinoids or items like THC and CBD? Well, the thought is that there are patients who have endocannabinoid deficiency. So they have a lack of production or maybe just a decreased production of those endogenous cannabinoids, whether it's AEA or 2AG. And we can utilize phytocannabinoids like THC and CBD to help replenish or restore the function of the endocannabinoid system. Or, for instance, with CBD, it can actually help increase some of those endogenous cannabinoids. So THC, as you can see, it's a partial agonist to cannabinoid receptor 1 and 2. And when you think about, or if you know some of the side effects that we worry about with THC, a lot of those are centrally active side effects like euphoria, maybe some dizziness, which makes sense because it's acting on those CB1 receptors in our central nervous system. So that was just a brief overview to talk about the endocannabinoid system. And now we're going to jump into a lot of the clinical considerations that we should have with cannabis use. So, first and foremost, drug interactions and drug considerations. There's a lot of evidence out there, theoretical evidence. There's actually only a few, what I would say, case reports and case studies for interactions with either THC or CBD and medications. However, there are some considerations just knowing the side effects of THC and CBD. So one, cannabinoids could decrease concentrations of clopidogrel. So they do act on our cytochrome P450 enzymes. Both act on 2C9, and so there's considerations with medications that are metabolized by 2C9. And then areas or medications that they could increase, one being alcohol. There's actually a lot of evidence where utilizing cannabis products with alcohol increases the CNS depressant effect. Anti-epileptic medications, the ones that I have listed here are ones where there's some case reports and case studies that it could increase those levels. And then some of our other CNS depressants like antipsychotics, benzodiazepines, just want to really utilize caution if patients are on these medications and we're going to be adding a cannabis-based product. The other one that is also established in literature is warfarin. So there are quite a few reports of patients who utilize either THC-based products or CBD-based products and really have an elevated INR. For those who may not be familiar with warfarin, that's one of our anticoagulants, so our blood thinning medications. And when we have a high INR, it increases that risk of bleeding. And so there's been reports of usually INR is a level of 2 to 3, reports of like 8 or greater with utilizing THC and CBD. So, a question that I commonly get, from audience members is, well, what if you have a patient who is on warfarin and, they tell you that they're utilizing cannabis or they really want to utilize it? I treat it just like I do whenever I'm talking to patients about their leafy green vegetables. Stay consistent. So if you're going to use a cannabis product, try to use roughly the same amount every day or at least the same frequency so that we don't see major fluctuations in your INR. If you do decide to, stop taking the cannabis product or increase the dose, then that's something you need to communicate with your provider. And then I added this picture. So this is just taken from Up to Date. It has a drug interaction section. You can also use Micromedics as well. Whenever I first started diving into cannabis research and I would get questions, clinically, a lot of them were related to drug interactions. Hey, this patient told me today that they're taking, THC. Do you know if it's okay with their medications? And I tried to, run it through all of the drug interaction databases that I could think of, and I could never find an interaction. It wasn't available. But now almost all the platforms that I'm aware of do have cannabidiol and THC as an option. So you can input those along with their other medications, and then it will spit out, what the risk is, what the potential interaction is. So for this example, I did a few medications that we may commonly see our patients on and typed in cannabidiol. And the interaction that is below is with cannabidiol or CBD and escitalopram, which is one of our antidepressants. And you can see that there is the potential for CBD to increase the concentration of escitalopram. And then it talks about monitoring that you could consider as well. And so, for our older adult population, definitely want to monitor on changes in adverse effects that they could experience. And then there is a risk of QTC prolongation with escitalopram, so we may want to repeat an EKG for that patient. So just something to consider if you have a patient that wants to start a cannabis product or that you find out is taking a cannabis product. So this slide, I would say if I want you to walk away with anything, it's knowing the contraindications to these products. So for THC, a condition that I absolutely do not recommend utilizing THC in a patient if they have is a history of acute psychosis, even a family history of acute psychosis. They've done multiple studies and found that patients with a family history or with a history of unstable psychiatric conditions, psychosis, THC can actually cause acute psychotic events. So that is a major contraindication. Another, what I have listed here is a warning, but I honestly was considering moving it up to more of the contraindication is patients who have a cardiovascular history, specifically of an arrhythmia. They have found in multiple studies, especially recently, where when they compare patients who utilize THC, and I will say it's primarily smoking THC, so smoking marijuana, um, they have found new onset arrhythmias. So patients who have never had an arrhythmia actually causing new onset arrhythmias, but then those who have a history of arrhythmia causing the patient to have an arrhythmia. So compared to those who were non-users. So for me, that's another, patient population where if the patient says, I want to try cannabis for my pain, I've tried all these other things, or I don't like opioids, I would really stay away from the THC based products and think more along the lines of a CBD product. For both products, I have warnings listed for CNS depressant medications, again, just because of the increased effect of CNS depressant activity when utilizing cannabis products. Moving over to CBD, so really no major contraindications with CBD that I've really seen in evidence. Most of the evidence that we have with CBD is related to Epidiolex. And just to kind of give you an idea, the CBD based products that we can get either at dispensaries or that patients may find from an external source. The milligram is roughly 20 to 30 milligrams. It's rare that you see really high doses unless they use multiple like tinctures, which is where you see like the dropper being utilized. Whereas Epidiolex in those studies, they were studying CBD like greater than 500 milligrams. So for some of these warnings may cause liver injury. That was really with those high doses of Epidiolex that patients were utilizing. Another one that may not be as relevant to our patient population, but I think, if you have friends or if you know of other people who are utilizing CBD-based products is male reproductive toxicity. So specifically in mice studies, they found that there can be damage to fertility in males or male offspring of females who are utilizing CBD. I think we need, more studies to determine the effects of that. But for me, a general rule of thumb is definitely any pregnant female should not be utilizing a cannabis-based product. There's a lot of studies out there that say that, but with CBD, you can have that potential risk of male reproductive toxicity. Okay, so let's talk about some of the adverse effects or side effects. So the effects that I have listed here, I would say, may not be negative side effects for some patients. So that's why it's just effects of THC and CBD. Starting from the top, analgesic effects. So both THC and CBD can have some analgesic effects. Anticonvulsant effects, we see more evidence with CBD in being an anticonvulsant agent. Both can potentially have some antiemetic effects. And then anti-inflammatory, antioxidant, and then antipsychotic or anxiolytic effects are more commonly seen with CBD. So we see what I would consider maybe some more of the positive results, such as anti-inflammatory with our cannabidiol-based products. Euphoria, not seen in CBD. It can be seen, I will say, in products that have a mixture of THC and CBD, but that is because of that THC component. So you may hear a patient say, like, oh, I tried a CBD THC product. It's really important to look at how much THC was in that product versus the CBD. There is something called the entourage effect that when you use THC and CBD together, if you use more CBD, it actually so CBD can actually bind on those CB1 receptors and not allow THC to bind, which decreases those CNS effects and can allow THC to have to not have those psychoactive effects. And then both can potentially cause some sedation. I will say with CBD to be a stronger sedative, you need pretty high doses. But overall, at doses of roughly 25 to 50 milligrams of CBD, you can have more of a relaxation effect. And then tachycardia and hypertension only seen in THC. And I should also put, I have seen reports for both CBD and THC to cause orthostatic hypotension, which is something that we should definitely consider in our older adult population. In terms of tachycardia, this goes in line with the arrhythmias. There are reports of increasing heart rate 40 to 60 beats per minute in patients who utilize THC. So that is definitely substantial. So what are our side effects of CBD? I do feel like more patients are utilizing CBD just because they know that it doesn't cause like the euphoric effects. And so the most common effects that I've seen are GI related side effects. So like nausea and diarrhea. Some patients can have a headache and then a little bit of that sedation and fatigue. And both CBD and THC can cause dry mouth as well. So that's something to consider. I didn't have it on my drug interaction list, but both tend to be a little more anticholinergic in their properties. And so for patients who are already on anticholinergic medications, whether it's for urinary incontinence, that's something to consider. So other patient counseling standpoints, so I've, discussing with patients, these products are not regulated like your prescription medications are. The second biggest thing that I really like to talk to patients about is storing the product in a locked location. There have been a ton of reports of children, especially here in Colorado, children, finding these products and taking them, and an increase in emergency department visits for young children. And so, I really try to encourage our older adults and say, hey, just make sure this is stored somewhere high. If I would prefer it in a locked location. But a lot of the products out there, especially ones that you find in dispensaries, it looks like candy. It looks like something that I would want to take. And so when kids see that, they utilize that. The other population that will tend to find these products as well are animals. So there have been an increase in vet emergency visits related to cannabis too. So I really try to discuss that with patients. Again, I've already mentioned, combining with alcohol leads to an increase in side effects. And then lastly, for our patients who do drive, these are recommendations for the state of Colorado. So their recommendations is that wait 6 hours after smoking marijuana before you drive, and then wait at least 8 hours after eating or drinking. And that's because cannabis products, whenever you like utilize, let's say, an edible product that you're eating, it has a variable onset. So some patients, they may feel the effects of that edible product within 60 minutes. Other patients, there have been reports of patients that it takes 3 to 4 hours before they feel that effect. And then those effects can last up to 8 hours. So for patients, definitely patients who are utilizing these products for the first time, I tell them try to utilize this product like when you have no plans to do anything, just to see how it impacts your body. Even if it's just CBD, because I don't know how sedating it may be to that patient. Everybody is different. So that's just something that, I really try to talk to patients about, like, do not drive, do not leave your home. And if at all possible, like, if it were me trying a product, I would try it at bedtime so that if I did have bad side effects, hopefully I'm going to sleep through it. Maybe wake up with like paranoia or something. I don't know, but, but at least I'm not out on the road, doing that. So yes, those are just kind of general rule of thumbs and conversations that I have. Okay, and then something else so this is something that I've sent patients who are utilizing a cannabis product, and actually I got this idea so whenever I moved to Colorado and I was doing that study on cannabis and migraines, I visited a few of the dispensaries, the ones who basically have the plant. It's plant all the way to product. And they walked me through their whole process. And it was very fascinating. And I talked with one of the owners of the facility and, was telling him that I work in patient care. And he said, yeah, I really love it when my patients take pictures of the products they utilize. They come in and they're like, hey, this product made me feel this way. And then they know kind of, they can see what the product is, and potentially recommend something different if the patient wants to do that. So it gave me the idea of, oh, why not, create a cannabis log for patients where they write the product name, they write what's in the product. They list all of the doses because if it's a product that contains multiple cannabinoids in it, it has multiple doses. They state what time they take it. Did it work? Yes or no? So if they're utilizing it for sleep, do they feel like it's improving their sleep? And then what side effects they have, whether they think it's good or bad, just like what did they feel? Um, so this is something that I have saved on the computer that if I'm meeting with a patient in person, I'll give that to them or send it through my help connection. And then as a pharmacist, I would not do my diligence if I didn't talk about the medication list. This was a battle that I had whenever I started my position at the seniors clinic and I was talking to a lot of patients about cannabis use. And I realized, we have patients who are utilizing this for pain, utilizing it for sleep. And I really want a way to put it on their medication list, but there was no way to do that. And since I did my residency here at the University of Colorado, I knew a few contacts within the pharmacy team and even the pharmacy epic team. And I sent them some emails and said, hey, is there any way that we we could just add like THC and CBD. I really want this on here. They were totally against that because, not feeling comfortable with patients having, these unapproved medications, unapproved products on their list. But guess what? Calcium is not FDA approved. Like we have a ton of supplements that are on those lists that I feel like also cause harm, but they're still on the medication list. So eventually, we did at least have CBD added to our medication list. So CBD. Yes. So if you have a patient that's on CBD, you can type that into the medication list. Now for THC, we are still here, unable to find. And the best that we can do is you can fill out, the dosing information if you have that. And under the medication name, you can write THC. But this is where we are at. So a little bit of progress, but I do think it's really important that if patients are on these products, that they're added to their medication list. And one thing that I am not covering today, but I know that there are some people here who work on the inpatient side is it would be really helpful for you as an inpatient provider if you knew a patient was utilizing something like THC, because when they come to the hospital, they're no longer getting that THC anymore. And you can have definitely patients can act very differently when they have been on, higher doses of THC and then they're off of them for 3 to 5 days. Maybe they start to have some confusion or they start to have some agitation and you're trying to figure it out. And it's because they were utilizing THC. So just something to think about. All right, so now we're going to get into our risk and benefits discussion. So evidence in older adults. Okay, so benefits. These areas, I would say, are the most studied areas for cannabinoid use. Chronic pain, there are a lot of studies that have been completed looking at chronic pain, specifically benefits of cannabis in neuropathic pain. Other areas, multiple sclerosis. We talked about CBD for that rare form of epilepsy. Inflammatory bowel disease is another area that has quite a bit of evidence. I haven't dove quite into that evidence as much, but I know there are a lot of studies out there. And then patients who have cancer and utilize THC, there have been reports of sleeping a bit better for those patients. And thinking of harm, so we have some benefits, some of our risk, driving, having car crashes. There's a lot of evidence out there to support the risk of driving impaired. And then we've talked about psychosis, but even more interestingly, there have been a few studies that have looked at patients who are on antipsychotics and utilize cannabis. They actually found a decrease in their adherence to their antipsychotic, which I don't know that that's great. I think it's very risky for a patient to be on an antipsychotic and then, go a few days without taking it. So just, concerns with that. And then applicable to our patient population, verbal recall and memory concerns. So first, we're just going to dive in to one study that looked at cannabis and chronic pain. So a systematic review of 18 placebo-controlled randomized controlled trials, and then 7 observational studies. So the mean age was, included some older adults, 50 to 65 years. And one thing that I really liked, and the reason that I want to go over this is because I like how it broke down like high THC concentration, a comparable THC to CBD concentration, and low THC concentrations in the studies. The most common pain was neuropathic pain with a baseline pain score of 5 to 6. And then you can see they had the most studies that included that high THC component. And those studies included those products that I mentioned earlier, dronabinol and nabilone. So those are our synthetic THCs. As you can see here, kind of breaking down the different studies, the high THC study, primarily neuropathic pain, but did include some studies that specifically looked at fibromyalgia. And they did note what they called a moderate improvement in pain. So if you look at that pain score, a decrease in a little more than a point, which I would say could be clinically significant. It was statistically significant, and they did note, in terms of safety, sedation, and dizziness, which is something that we would expect from, a synthetic THC product. So for both dronabinol and nabilone, they can cause similar side effects as like whole plant THC can, and have some anticholinergic properties as well. So these adverse effects make sense to me. For the comparable study, so this is using a 1-to-1 ratio. They specifically looked at nabiximols, which is Sativex. I don't know if you guys have heard of that, but it's widely used in Europe for multiple sclerosis and neuropathic pain. And it's a roughly a 1-to-1 ratio. It's an oromucosal spray that patients can use, and you can kind of titrate your dose by utilizing this spray. You can see the most common reason for use was neuropathic pain, and they had some small improvements in pain. And I would say, based on this information, I don't know that this is a clinically significant difference in pain, but maybe that would, depend on the patient. Again, even though it is roughly a 1-to-1 ratio of THC and CBD, they still had incidents of dizziness, sedation, and some nausea. And I think the reason that we're seeing that nausea is from that CBD component. Unfortunately, with the low THC products, which is, honestly the area that I'm most interested in because I feel like CBD seems to be more safe, they had insufficient evidence to evaluate. So the studies just didn't really report a lot. And there were so many different products that the patients were using. They just kind of, had their grab bag of products. So unable to evaluate pain. So, looking at this, you can see the different studies that were evaluated. The top are our synthetic, high THC, so dronabinol, nabilone, and then our extracted THC, so extracted from the plant. And you can see that, pain, in terms of helping with pain, it does favor the cannabis product. And then for the comparable THC, CBD, so that nabiximols, again, it does look like it favors that nabiximols product, but maybe just a few more where it's hard to determine if there was really a difference compared to placebo. Okay, so then there was another review that specifically looked at studies outside of chronic pain, which I think is definitely an area that I'm interested in and excited that there's new research or more research being considered. And these were the three things that they looked at. So end stage cancer, Alzheimer's disease, dementia, and then Parkinson's disease. And we are going to focus more on the Alzheimer's disease and dementia because there is more and more research being done in this field. However, the overall conclusions that they found with potential benefits and potential harms, you can see for patients with end stage cancer, potentially help those patients with their anxiety, with some of their depression, cancer pain, and then helped with the nausea and vomiting, as well as quality of life. But then potential harms, so that Sativex or that nabiximols, it actually decreased appetite in patients. And I think the main reason is because it is this oromucosal spray and it can change your taste. And so I think that just had a negative impact on those patients, which we definitely don't want for patients who have end stage cancer. There were also psychoactive effects for those patients as well. And then if you look down at Alzheimer's disease, you can see the potential benefits. So agitation and aggression, which is what we're going to discuss next. And then you can also see some of the harms, balance, psychedelic effects, and sedation and somnolence. For Parkinson's disease, a lot of benefits and the potential harm in some patients reduce their quality of life, specifically with CBD. I didn't see much more information on, what it reduced, but whenever they did a questionnaire, that's what it showed. Okay, so let's transition into cannabinoids and Alzheimer's disease. So this is the thought of, in some research that they have performed in mice where they've looked at cannabinoids, and here's some of the potential effects that they can have. So one inhibits acetylcholinesterase activity, which is very similar to what some of our Alzheimer's medications like donepezil do. Um, Also reduces neuroinflammation, antioxidant activity, and then you can see some of the others that are listed here as well. So specifically focusing on agitation, because I have had a few caregivers who, through some of our providers, I've spoke with about utilizing cannabis products for agitation. This is a systematic review of 12 studies. You can see the MMSE ranges from 4 to 22, so really encompasses severe to mild, and 4 of the 12 studies found significant improvement in the neuropsychiatric symptom score. So, specifically, the neuropsychiatric inventory was reduced by about 10 to 11 points after 28 days of dronabinol use. And they also found significant improvements in the Pittsburgh agitation scale as well with dronabinol. However, 8 of the studies found no benefit. So, based on this, it appears to be some mixed evidence based on these studies. And I think a lot of it had to do with, difference in dosing, also assessing different neuropsychiatric just scales and agitation scales as well. But, whenever you're globally thinking about the most common side effects, those were sedation and dizziness, which we would expect from those synthetic THC products. So next, I wanted to go over this pilot data. So THCAD, which some of you may have um, heard about this study. So this is currently an 8-year study that has been going on. Started before the pandemic. So as you can imagine, the pandemic really slowed a lot of things down, and was initially started as an inpatient trial. So looking at patients who were institutionalized, but then they actually expanded it to outpatient. The goal is to enroll 80 patients. So it's a 3-week placebo controlled randomized controlled trial for adjunctive treatment of agitation in patients with Alzheimer's disease. The intervention is dronabinol 5 milligrams twice daily, administered at 8 and 2. The half-life of dronabinol is roughly 4 hours, so they're hoping to help mitigate some of the sundowning effects by administering it at 2 p.m. And there is publication of kind of the preliminary information. So 58 participants, which is what you can see here, where the mean age is 78 years. And then you can also see the exclusion criteria for the participants. The baseline information is also of these 58 participants. And so you can see some of the scores that they have listed here for a lot of those neuropsychiatric or the agitation um, questionnaires and analysis, as well as their MMSE of 8. So that would equate to severe in terms of their Alzheimer's disease. Now, in the last column, so these are not the results of the 58. So these results in the very last column were presented at a meeting in October. And so they haven't published that information yet. But what I could find from that meeting, they have 75 patients. So again, goal 80. And for the Pittsburgh agitation score, you can see that they had a 30% decrease in patients who were utilizing dronabinol. Now, again, this is adjunctive therapy. And so I think, the question is, and what I want to know is, you know, I is this clinically meaningful? Is this something that the caregivers feel is helpful, for these patients? Because it was, initially started as inpatient, but then they included outpatient. Um, and so, just something to consider for the Pittsburgh agitation scale. A score of 4 or more is severe behaviors. So, maybe it reduced some of the severity of those behaviors. For side effects that were noted, really, really minimal, honestly, in terms of number. So there were 2 patients who had delirium, and I'm not saying that that's a minimal side effect. I would actually, agree that that is not a great side effect to have, but side effects weren't very common in a lot of the patients. There was one patient who had a fall with injury, and then sedation. So I really think the use of dronabinol, would have to be in a certain patient population, maybe not a patient who is bedbound, but maybe a patient who has, like, a caregiver with them, so that they can really help that patient and try to avoid some of these, side effects like falling and, being overly sedated. So the last thing I want to touch on is sleep. And I will do this quickly. So CBD for sleep. So this was a study looking at patients who went to a psychiatric clinic, and the patients either had anxiety or sleep. Um, I know that the average age is not our patient population, but they did include some older adults. And one of the reasons that I wanted to include this is because a lot of the patients that I talk with who want to utilize a cannabis product for sleep also have anxiety, or they just have other factors that are impacting their sleep. So it's never just like, hey, I'm great. And the only thing that is wrong is like, I just have poor sleep. Like, usually it's me and behavioral health that are working together to help them with their sleep. So there's other factors that are involved. So this study, they looked at CBD, a capsule, 25 milligrams, and that ranged anywhere from 25 to 175. They did note, so 175 is a pretty high dose, but that was only one patient. The majority of patients were on 50 to 75 milligrams. You can see the rating scores that they looked at, and they followed up at 1, 2, and 3 months. So baseline data, you can see that for anxiety, you can see that by 3 months, there was a pretty substantial decrease in their anxiety scores. And then for the PSQI, which is the sleep measure, you can see that there was a decrease, and then it seemed to kind of increase a little bit more, leading to, that the effects of CBD appear to work initially, but then unless you continue to titrate that dose of CBD, those effects start to go away. And that's something that we need to further understand. But you can also see that for those patients who were just utilizing CBD for sleep. So they actually had great improvement in their anxiety, 22 down to 13. But for their sleep score, yes, it decreased, but again, it seemed to kind of stabilize. Another thing just to point out with this study is that by month 2, almost half of the participants didn't show up for follow-up. And by month 3, they only had like 25 participants. So not the best, data. The numbers just continued to decrease. And it wasn't because of side effects that they're aware of. It was just lack of follow-up, which I think we can all understand. Safety, they did have 3 patients drop out just due to fatigue. So, and then as I mentioned, I think overall for this, CBD appears to work well initially. I do think you have to titrate that dose to like 30 or 50 milligrams, but then those effects after about a month or two tend to decrease. And I've seen that in patients as well. And a lot of patients are unable to afford a dose higher than 50 milligrams because it's really expensive. And lastly, this was a cross-sectional study of 128 patients. And what they looked at in this study is it was just calling patients who were on a medical cannabis registry. And so they looked at medical cannabis users and then non-users, and asked them questions related to their sleep. So trying to see if medical cannabis seemed to have, positive or negative effects on sleep. These patients, so the products they were using, so it was whole plant cannabis, but the ratio was about 5 to 1. And then 40% were taking additional sleep medications. And the average cannabis use per month is 31 grams, which is equivalent to about an ounce. And for my understanding, I wanted to know, like, how much is this? So I found a picture. An ounce is a whole Ziploc bag. So I feel like that's a lot of cannabis. So, I am still learning about this world, but this is a lot. So I feel like I need to share that with, the results, because overall, the results of medical cannabis use, it was associated with less waking up at night. And I'm sure if like these patients are combining it with sleep medications, like I'm sure they're not waking up at night. That is just my overarching, comment on this. So unfortunately, these are the best studies we have out there for sleep. So we need you guys to do the research on that. And then no difference between groups in falling asleep or waking up too early between the non-users and medical cannabis users. So a summary of the evidence for Alzheimer's dementia, I would say mixed evidence for dementia-related agitation, but I am excited just to hear more and actually see the full study of that THC-AD with dronabinol, and see if we start to see that being utilized more. I would say our most evidence is within chronic pain and specifically neuropathic pain. And we need more studies for insomnia in patients who utilize it for sleep. So takeaways, first-line therapies definitely are recommended. And then if it's deemed appropriate for a patient to try a cannabis product, reviewing current medications, medical history, also discussing that certificate of analysis, and then going through what the patient should expect. And then, there is more robust data for neuropathic pain and a potential for dronabinol use. So with that is the end.
Kate.
Thank you, Danielle. I was wondering if there's data on how people improve their endocannabinoids themselves beyond replacement, or is there any data on that?
That's a great question. I haven't looked in that. Anytime I look at the endocannabinoid system, it basically talks about the use of cannabinoids to replenish that. And the only thing that I can think of is that the use of, again, it would be utilizing a cannabinoid, but the use of CBD can help prevent the degradation of our endogenous cannabinoids. But yeah, I'll have to look into that. Get back to you.
Thank you so much, Danielle. So you've got a person with chronic neuropathic pain. Do you do gabapentin or do you do a cannabinoid?
Yeah, great question. So I actually have a slide with our treatments, and I didn't include it for just because of time, but there have been multiple studies that have looked at, or not multiple studies, but there was a review that looked at basically the number needed to treat and number needed to harm with neuropathic pain medication. So included gabapentin, included tricyclic antidepressants, and then also looked at cannabis products, specifically the synthetic THC products like dronabinol, and it found that the number needed to treat between gabapentin and cannabis was actually similar. So I think for cannabis, it was like 3.2, and gabapentin, it was around 4. But the number needed to harm was very difficult to distinguish because gabapentin actually had dropouts, whereas the dronabinol use didn't have dropouts. It was more of just patients having dizziness. So they continued their cannabis, but just reported dizziness. So it was comparing apples to oranges. But just to go along with, FDA approved medications, I would recommend gabapentin over the use of cannabis.
A question from online from Josh Yarrow.
Yeah.
What, if anything, is known about how acute or chronic use of THC or CBD impacts sex steroid hormone in males like testosterone or females estradiol?
So that I do not know the answer to. I haven't looked into that area, but that is something interesting to consider. Yeah.
And then final question from Gretchen. Are there concerns for liver toxicity with CBD? And then separately, a recommendation for maximum daily dose of CBD, say in an older adult?
Yeah, that's a great question. So there were some reports with Epidiolex of liver toxicity, but again, those were doses of so the liver toxicity, I think were doses of like 800 to 1,000 milligrams. So very, very high doses that our patients, I would say, would not be able to get unless they drank like a whole bottle of CBD that they get from, a dispensary or external place. And then for maximum doses, I really think that's going to depend on the patient's budget. I usually will start at 20 milligrams, and then I've had patients successfully titrate up to 60 milligrams a day and not have any adverse effects. Beyond that, like personally, I would say anything over 100, I just get a little more uncomfortable with, because knowing that doses around 100 and greater can really have more of those like sedative, almost benzo and Z drug-like properties. So hopefully that answers.
Get to Sunny's question, but really appreciate everyone's participation. Please fill out the evaluation and then go upstairs to mingle and see the doors. Thanks, everyone.